I am proud to introduce Dr. Alec Moorman of the University of Washington cardiology faculty at the UW Heart Institute. He is mainly stationed at the Eastside Specialty Center, but also supports some of our other clinics as well, which we'll talk about at the end. But again, I'd like to thank Dr. Alec Moorman for presenting here the essentials of prevention in cardiovascular care. Just some logistics as we go through this presentation. Dr. Moorman, if you do have any questions throughout the presentation, please type them into the chat, into the Q&A. We will take those questions at the end of the presentation, so we'll make sure that your questions get answered. And we look forward to having you here. And Dr. Moorman, please take it away.
Great. Thank you so much, John Michael. And thank you for having me this evening. I feel honored to be going first in this series of classes or lectures that we have planned for Heart Month. So first, just an outline of my talk. I'm glad that you're here with me tonight so that you can learn about prevention from me rather than Philip Morris here in this classic ad. And as we say, an ounce of prevention is worth a pound of cure. But the things that we're going to review today, first, I'd like to review with everybody the patient assessment tools that we have to assess somebody's risk for cardiovascular disease. And then we'll talk a little bit about special tests that we sometimes use to further refine that risk. And these are tests that you may have heard about, and you may be wondering whether they're right for you. And then I'll focus most of the talk touching upon lifestyle interventions to optimize your cardiovascular risk, so diet and exercise. And then lastly, a few comments about aspirin, which has been in the news recently, and I've been hearing lots of questions about aspirin in my clinic. So first, I wanted to present these two celebrity cases that really brought cardiovascular disease and prevention to the forefront of people's thoughts. The first case here on the left of the screen, Jim Fixx, he was a famous runner, and he really helped revolutionize jogging as a sport and a recreational activity in the United States in the 1970s. And his personal story was that he was aware of a strong family history of heart disease, and his dad died young of a heart attack at the age of 43. Jim was a smoker, he was not fit, and he got himself in shape running, and he was really the poster child for what lifestyle prevention could do to you. And because of that, everybody was shocked when he died suddenly while running at the age of 52. And then here on the other side of the screen, we have Tim Russert, who many in the audience probably remember was a beloved broadcaster and the host of the Meet the Press show. He died of a fatal heart attack at work at the age of 58 while he was on set. And what really troubled people and sparked a lot of conversations in our clinics was that people knew he had coronary disease. And in fact, he had passed a stress test just weeks prior to this fatal event. And people wondered, why could that happen? And how can I prevent that? So with this slide, I just want to share with people, moving left to right across the screen, this is a diagram of what happens to arteries over time and how they can go from healthy here at the early ages and to heavily diseased. And what we see here is over time in the artery wall, cholesterol plaques can build up. And it's when these plaques rupture out from the wall into the bloodstream that the blood clots, and that's what triggers a fatal heart attack. So the idea of prevention are the things that we do over here earlier in our life, or even in middle adulthood. We hopefully will make a difference to prevent the risk of this later in life, or prevent these sudden events that we hear about in our community. And because there's such an interest and it's so important to reduce the risk of heart disease, the American College of Cardiology and the American Heart Association have written guidelines for practitioners, doctors and other providers like me to help counsel patients and improve their health to prevent cardiovascular disease. And this document, this is just a screenshot of the document. It's over 50 pages long. This is a resource for healthcare professionals with lots of great information, and it shows us the evidence. So when we're counseling patients in the clinic, this document supports the things, it provides the evidence for what we tell people. So I want to start with a patient case that can help illustrate how these conversations go in clinic. And this is a real patient that I have seen in my own clinic. So this is a 46-year-old Indian woman with a history of high cholesterol, and she has a family history of heart disease in each of her parents, each of whom had heart attacks in their early 60s. So she's coming to clinic now because she would like a cardiovascular risk assessment, and she wants to know specifically if she should be on cholesterol medication or if there's other interventions I would recommend for her. She exercises regularly and has no concerning symptoms like chest pain or shortness of breath. She does not have any chronic medical conditions, no diabetes. She doesn't smoke, and she never did. And she has normal vital signs and a normal physical exam. But you'll see here that she does have elevated cholesterol. She has a total cholesterol of 245, and HDL, which is the good cholesterol, which is normal, but her quote bad cholesterol, LDL, is elevated at 182, and she has normal triglycerides. So she's wondering, what is her risk of a heart attack or stroke in the future, and what can she do to minimize that risk? Well, we do have patient assessment tools that we can use to help calculate and quantify somebody's risk and share that with the patient and help guide decisions. And the guidelines tell us that for adults between the ages of 40 and 75 years of age, clinicians should routinely assess traditional cardiovascular risk factors and calculate the patient's 10-year risk of atherosclerosis, which you'll see in my talk is abbreviated as ASCVD, atherosclerotic vascular disease. And what I've listed here are some risk calculators that you can find online yourself and we use in the clinics. And these are risk calculators that incorporate clinical risk factors to quantify somebody's risk. And probably the most commonly used is the risk calculator from the American College of Cardiology and the American Heart Association, or what's called the pooled cohort equation. And I'll walk you through this. So first of all, who is at risk and what are the risk factors and when did we learn this? And this is a really interesting story. So some of you may have heard of the Framingham study, and our older risk calculator was actually called the Framingham risk score. And the Framingham heart study is a long-term cohort study on residents of Framingham, Massachusetts, which is a suburb of Boston. And this study was actually commissioned by Congress in the 1940s to try and learn why there was this heart disease epidemic in the United States. And all of the things that we know now and we take for granted about what risk factors are for heart disease were discovered mostly from this study. So the first cohort was enrolled in 1948, and there was over 5,000 patients. And then there has been subsequent cohorts, which are the offspring of these people. And then there was an effort more recently to try and improve the diversity of this cohort, because the early cohort was almost entirely white, upper middle class people. And prior to this, there was really little known about the epidemiology or the causes of heart disease. And this study is still ongoing. And what we learned, the term risk factor was coined in this era. And looking at these slides here, if you focus here on the left, these are the single risk factors they identify. And what's listed here is an odds ratio. When you compare people who've had an event like a heart attack to those who did not, this is the odds that they had the risk factor that we're showing here. So a body mass index greater than 27, which is in the overweight category, a history of smoking, total cholesterol greater than 220, diagnosis of diabetes or hypertension. Each of these things individually increased the patient's risk of 1.5 to 2-fold. But you see here when you add the risk factors together, and there's multiple risk factors, the odds of having a cardiovascular event like heart attack or stroke were much higher. And similar data presented in a different way, these lines show you the lifetime risk of a cardiovascular event for a patient. If we start here at the age of 55, the more risk factors we add, the higher one's lifetime risk of having a cardiovascular event. So these are the risk factors we focus on for prevention. And when we measure these risk factors in clinic and include patients' demographic data like their age, their sex, race, or ethnicity, we can calculate somebody's risk of cardiovascular disease. And this is just a screenshot of the risk calculator from the American College of Cardiology. This is available on websites, or there's an app that we have that we use on our phones. And this calculator will tell you somebody's 10-year risk of heart disease. And then it will actually also include a statement or a recommendation about the discussion that should be had and the treatments that should be considered based on somebody's risk. So we use that a lot in the clinic. Now, in addition to traditional risk factors, we also have what are called risk enhancers. These are clinical factors that we recognize increase somebody's risk of cardiovascular disease, but are not included in the risk calculators as those core traditional risk factors. But these are additional things that are important that we consider. So there's family history of premature heart disease, people who have persistently high LDL cholesterol, kind of in the high but not extremely high range, patients with something called the metabolic syndrome, which is a clustering of risk factors like large waist circumference, prediabetes, high triglycerides, patients who have chronic kidney disease or chronic inflammatory disorders like rheumatoid arthritis or HIV. The guidelines also talk about certain high-risk ethnicities, such as South Asian ethnicity, and this can be accounted for by clustering of risk factors in certain ethnic groups. There's triglycerides that are elevated. And then some of the specialized testing that is not routinely done in everybody, but I'll talk about some of these today, but these are things that might be available to the clinician who's counseling the patient. So ApoB, which is a special cholesterol test that I'll talk about a little bit, CRP, which is a commonly used screening tool in primary care clinics, which is C-reactive protein, ankle brachial index, which is just measuring somebody's blood pressure in their arm and their leg, and then taking the ratio. And then elevated lipoprotein A, which is another specialized cholesterol test. So first I want to pause and make a few comments about race and risk. So our risk calculators incorporate race, but I want to point out that race is a social construct and it's not a discrete risk factor. And race and ethnicity are actually poor surrogates for genetics. Risk factors can cluster in groups of people, but the risk associated with race or ethnicity often reflects socioeconomic disparities, structural racism, and other non-biologic factors. And our guidelines do have a statement that it's important for clinicians to consider the socioeconomic inequalities that our patients might face, which can be strong determinants of cardiovascular disease risk. And we should tailor our advice to the patient in front of us, taking into account cultural preferences, work, or home environments. And that's critically important because the risk assessment and the counseling discussion really has to be individualized for the person in front of us in the clinic. So a few words about cholesterol testing. Probably everybody in the audience has had it. Cholesterol testing is part of standard cardiovascular risk assessment. Now, what we get in the standard lipid profile is a measurement of the total cholesterol concentration, the LDL cholesterol concentration, the HDL concentration, which is known as, quote, good cholesterol, and then triglycerides. Now, we as providers have really focused on, for the past few decades, really, of LDL cholesterol. LDL cholesterol is the strongest predictor of risk in the standard lipid panel. And we now know LDL cholesterol really is causal in forming plaques and arteries. It's not just associated with, but it actually causes the plaque. Now, ApoB is the actual protein that is in LDL cholesterol and can also be found in other types of cholesterol, which are demonstrated here in the picture on the right. So ApoB can be measured directly, and it's a little bit better than an LDL concentration, but it's not routinely done, at least not currently, but it is an available test. Some of you might have had it or you may have heard of it. It is recommended in the European guidelines for cholesterol testing. So this is something to know about. Now, something else people have heard about are subfractions of the cholesterol, or these advanced lipoprotein tests. And this is where people talk about their LDL particle size or their particle number. And I don't have time to go into that today, but this is not recommended for most people because the additive information there for most people doesn't really change how they're managed. But this is something that is available. Now, for certain patients who have moderate to high cardiovascular risk or who have very high LDL cholesterol, we know that statins are the cornerstone for medical treatment. Lifestyle interventions are always important, but statins are really the cornerstone for certain patients for prevention. And when you pool the data from all the clinical trials that have randomized patients to a statin versus placebo treatment, there's a very consistent reduction in heart attack and stroke risk by about 25%, and statins are safe. So I just want to say that because we're going to focus on lifestyle today, but there are patients for whom that medical treatment's appropriate, and there's a lot of misinformation out there. So you want to have a good discussion with your doctor if you have questions or concerns about the risk of a statin. Now, lipoprotein A, this is a special cholesterol test we will use for prevention assessment in certain patients. And this test is becoming increasingly well known. And lipoprotein A is a special type of cholesterol that's not part of the routine panel. And you can see here in the picture up in the right, it is very similar to LDL cholesterol, but there's this extra ApoA molecule attached to it. And that makes this lipoprotein A more inflammatory and more likely to cause plaques in arteries. And the really interesting thing about lipoprotein A is it is entirely genetically determined. It is not influenced by environmental factors like how much you exercise or what you eat or how much alcohol you drink. So this is really a genetically determined risk factor. And the studies have really shown that it's a causal risk factor. It's not just associated with heart disease, it actually causes heart disease. Now, the interesting thing about lipoprotein A, statin medications actually do not lower it, and we don't currently have any FDA-approved therapies to lower lipoprotein A. There is a special kind of cholesterol drug that lowers lipoprotein A that's approved for other conditions, and that's under more investigation. And then we here at the University of Washington are part of an international trial looking at a investigational drug to lower lipoprotein A, but that trial is not for prevention. That's for patients who already have had heart attacks or strokes. But so when do we use this in prevention counseling? I think there's the main scenario is when a patient tells me that they have a very strong family history of premature or early onset heart disease, but there's not traditional risk factors in the family that seem to explain that. We'll look for this lipoprotein A to see if there's a genetic reason for that. And then the other circumstance, I know I'm talking about prevention today, but if I see a young patient who's already had a heart attack or stroke and the reason or the explanation is not obvious, then I will test for this lipoprotein A. Now, C-reactive protein or CRP is probably better known to this audience because this is a test that's commonly ordered in primary care clinics, and it's used for a lot of different things. It's not specific to heart disease. This is just a blood test that measures inflammation in the blood. So this test will be elevated if you just had pneumonia or if you have a cold or if your rheumatoid arthritis is flaring. But for patients who don't have any of that going on, there's a lot of evidence that inflammation contributes to plaque formation in arteries. So this is a way to measure for background inflammation in a patient that might increase their risk of heart disease. And studies have shown that CRP is associated with risk for heart disease. And in fact, it's incorporated in one of the other risk calculators that's available to us, something called the Reynolds risk score. And this test has been shown to be useful in certain situations, as demonstrated by this Jupiter clinical trial. This was a trial where they took patients who had non-elevated cholesterol, which they defined as an LDL concentration less than 130. But for those patients and who with normal or non-elevated cholesterol, but who had a high CRP, they randomized the patients to getting a placebo or a low dose of a statin. And the statin actually lowered their risk of heart attack or stroke significantly. It lowered it so much that they stopped the clinical trial early. So this is a way that some people, some clinicians will use CRP to help further refine risk. And if that CRP is elevated, that might push the patient and their provider to start a treatment to lower risk. And this is just a screenshot of the Reynolds risk score, which if you've had your CRP measured and you know this other data, this score can tell you your 10-year risk of heart attack or stroke, similar to the other risk calculator I showed you. And I just wanted to point out here that this score is kind of cool because it was originally derived in all women, over 24,000 women, and then it was subsequently validated in a cohort of men. So historically, a lot of medical studies have underrepresentation of women, but this one did not. Now let's continue our case. So the patient that I described earlier, she's had persistently high cholesterol, kind of in the 160s to 180s, her LDL cholesterol, and she has her family history I mentioned. And we checked her lipoprotein A, and it was actually elevated. So I had a discussion with her, and I recommended considering a statin medication to lower her risk of heart attack or stroke by about 20 to 25%. But she's reluctant. She's young. She's otherwise healthy. She doesn't feel bad. She doesn't necessarily want to take a pill every day for the rest of her life. So is there additional testing that we could do that would help her make this decision? And the answer is yes. There is another test that is commonly done, and there's been increased utilization kind of in medical clinics in the community, and that's a coronary calcium score. So coronary calcium score is simply a CT scan of the chest without injecting any contrast. And this test takes advantage of the fact that calcium shows up as very bright on CT or X-ray imaging. It's very easy to see. And a computer program can quantify the amount of calcium in the heart arteries when you focus the CT scan in the chest region, and that gets reported as a total coronary calcium score or an Agatston score. And this picture here on the right shows us calcium in the patient's left coronary artery. It's very bright. If you compare where this giant yellow arrow is pointing, that's an artery. This out here in the chest wall, these are the ribs. So this artery looks just as bright as the bone in the chest wall or the bone in the vertebrae. Now this score is, or this testing is best utilized in patients who are kind of an intermediate risk, where maybe you're on the fence, you or the patient are on the fence about what to do. So if you got a coronary calcium score and it's elevated, that would push you towards treatment. If the calcium score is 0 and there's no calcified plaque in the arteries, that would downgrade the patient's risk and might reassure you. So that's really the sweet spot for this test. Now, this is just some data I'll go through quickly. I don't want to show too many charts and data slides in this talk, but if you look here on the left, this was a large study that looked at patients who'd had coronary artery calcium scores, and it stratifies the patients. The gray were people who had a score of 0, so no calcifications in the heart arteries. The dashed blue line is patients with kind of a low score of 1 to 100, and then green is 100 to 400, and red is greater than 400, which is very elevated. And you'll see that if you look at heart attack risk or stroke risk, or if you pool all cardiovascular events together, or if you look at mortality, the higher the calcium score, the higher the risk of having an event over 15 years of follow-up time. So finding high coronary calcium levels identifies a patient who's at higher risk. And that risk holds. This figure on the right shows us that that's true whether or not the patient has major risk factors, whether they're over the age of 50 or under the age of 50. So really at any, no matter how you slice and dice this patient population, the higher the calcium score, the higher the risk. And the guidelines tell us that if your patient is intermediate risk and you get a calcium score, if their score is not 0, that would favor a statin. And if the score is greater than 100 or greater than the 75th percentile for the patient's age group, then a statin would be recommended. Now another data slide, but I think this is an important concept. So it is the plaque burden, the total plaque in the arteries, not the degree of narrowing, that predicts future heart attack risk. If you look here on the left, the higher somebody's calcium score is, the more likely they are to have obstructive coronary artery disease, which we define as an artery being narrowed by more than 70%. So that's definitely true. The higher the calcium score, the more likely somebody is to have a moderately or severely narrowed coronary artery. But here on the right, when you look at all the different strata, when you divide the patients up by their calcium score and compare patients with non-obstructive versus obstructive, their risk is the same. And the reason this concept is important is for years, doctors have really focused on the percent narrowing of the artery, which tends to trigger a response of putting stents in arteries or recommending bypass surgery. But before those things are considered, it's really important that patients are on a foundation of good medical therapy and lifestyle changes to reduce the risk of a plaque rupturing suddenly. Because back to that first figure I showed you, it's that sudden rupture of a plaque that triggers a sudden heart attack, like happened to Tim Russert or Jim Fix. And then just a couple more screenshots of risk calculators we have available to us using a combination of those traditional risk factors. And then when we also have a calcium score, we can include that data in the risk calculator and get even a better or more refined risk assessment for our patient. And then this chart summarizes the best way to use a calcium score. So if we look here at the top, this divides the patients into their 10-year risk of heart attack or stroke. And we typically define greater than 7.5 or 10% to be high risk. Less than 5% is low risk. So for low risk patients, a statin wouldn't be recommended under any circumstances. So we wouldn't check a calcium score. Now, kind of in this intermediate to high risk group, if we're not sure, if the patient's not sure or the provider's not sure that the statin's the right choice, then a calcium score could be useful because an elevated calcium score would upgrade somebody's risk and make us think maybe they should be on medical treatment with something like a statin. Whereas if their score is 0, it would push their risk back down, and that would spare them the medical therapy, at least for now. And then on the other end of the spectrum, patients who have very high risk because they have all the major risk factors, they smoke, they're hypertensive, they have high cholesterol, they're obese, a calcium score is not useful because we should be treating that patient. They're at such high risk, they should be on treatment even without knowing if they have calcium in their arteries. And this flow chart here summarizes kind of the algorithm for how we think about patients in our cardiovascular wellness and prevention program that we have started here at the University of Washington in partnership with our sports cardiology group and family medicine. And this chart's a little bit tailored to older adult athletes and how to assess their risk if they're interested in knowing that before they partake in training or competing even. But these are the studies I've referred to earlier in this talk, and that would be available for your reference later. Now let's move on to diet. So the American College of Cardiology and the American Heart Association give us great recommendations for the best diet for cardiovascular prevention. And I'll just make a plug for tomorrow night's webinar. Dr. Ruchi Kapoor will be giving an in-depth talk on diet. So she'll, I'm sure, provide you with more details than I have here. But what we recommend to our patients is that a diet emphasizing intake of vegetables, fruits, legumes, nuts, whole grains, and fish is recommended as the best way to decrease atherosclerotic vascular disease. And what this is describing is what's known as the Mediterranean diet. The guidelines also tell us that we should try and replace saturated fat with dietary monounsaturated or polyunsaturated fats. And the best example of a monounsaturated fat is olive oil, again, core to the Mediterranean diet. Reducing cholesterol intake is helpful. Reducing sodium helps control blood pressure. And I'm sure Dr. Alhama Balato will talk about this in her talk on Friday. There's a talk available on hypertension. And then we want to minimize the intake of processed meats, refined carbohydrates, and sugar-sweetened beverages. And then do not eat trans fat. Luckily, you don't even have that option anymore in the United States. It's been banned. So this is the Mediterranean diet. And where did the Mediterranean diet come from? Well, in the 1950s, epidemiologists noted that heart disease risk on the island of Crete was much lower than continental Europe. And so they started looking for cultural or lifestyle factors that would explain that. And what they realized was that there was this typical dietary pattern or portfolio of foods that patients in this region ate. And the interesting thing about the Mediterranean diet is the effects on cholesterol are pretty modest. On average, it will only lower cholesterol about 5 to 10%, but it really is associated with reduced risk of heart attack or stroke. And this study here, a more recent study, in fact, it was just published in the last week or two, very large cohort of over 90,000 people. They looked at dietary patterns, and when they compared people that ate more than half a tablespoon of olive oil per day and ate that instead of butter, there was a reduction in risk of cardiovascular disease and cancer death by about 20%. And we also have randomized trials. Most studies of diet are observational studies where patients just fill out surveys and report what they eat. And those studies are always problematic because their recall is not always perfect. They're not always 100% truthful maybe about what they're eating or how much they're eating. But we do have some randomized studies where patients or households were randomized to 2 types of diet. And this Predimed prevention trial done in Spain, they randomized households to a Mediterranean diet or the American Heart Association Step 2 low-fat diet. And the Mediterranean diet was better at reducing risk of cardiovascular disease. So we have very good data that the Mediterranean diet is the best all-around diet for risk reduction. Now, plant-based diets are also great. But most people don't follow a completely plant-based diet. It can be hard for people to change to that, but for people who do, good for you. We have lots of evidence that plant-based diets reduce cardiovascular disease associated with lower all-cause mortality, not just cardiovascular mortality. And this makes sense because we know that red meat and processed meats are associated with increased risk of heart disease. Another interesting finding, that Predimed trial I described on the last slide, some of the houses were plant-based, and those households, when they were on the vegetarian version of the Mediterranean diet, their risk seemed to be even lower. And then there was this Adventist Health study that also looked at plant-based diet and showed that replacing meat with nuts and seeds reduced heart disease risk. So plant-based diet's great if you already do that or if you're motivated to make a big change. Now, I wanted to talk a little bit about fat because there's always a lot of questions about fat. Is fat really bad? What fats can I eat? What fats should I avoid? So historically, studies that lumped all fats together did show that trans and saturated fats were associated with increased cardiovascular disease and death. But we know that when you break it down, not all fat is bad. And really most of the data showing that fat is bad came from trans fats, which are now outlawed. They were used a lot like in the baking and junk food industry because trans fats were more stable when they were stored. But when you look at these observational studies, there's a big cohort study that looked at people's macronutrients and their risk of cardiovascular events and also other types of disease. And they showed that carbohydrate intake was associated with increased mortality, but not necessarily cardiovascular disease mortality. So the more carbohydrates people ate, the higher their risk. But what was interesting is in this study, fat intake was inversely associated with mortality. And this fat meta-analysis, where they pooled a meta-analysis is a medical study where data from a bunch of different sources is pooled together and analyzed in a rigorous way. This fat meta-analysis showed that when you looked at saturated fats together, they actually were not associated with mortality or cardiovascular disease risk, only trans fat. And so the figure on the right here just tries to illustrate the difference between good fats, which are kind of common sense fats, versus bad fats. Again, a lot of this is kind of common sense. If the fat feels wrong, if it's fast food, processed food, junk food, it's probably not good for you. Now let's move on to exercise. So the guidelines have specific recommendations about how exercise can lower your risk of cardiovascular disease. And the guidelines have this very specific recommendation that we do 150 minutes a week or more of moderate intensity activity, or just 75 minutes a week of vigorous activity. And this chart just gives you examples. So moderate intensity activities, just brisk walking, gardening or yard work, cycling at a casual pace, ballroom dancing. Vigorous activities would be like jogging, brisk walking, like power walking, aerobics classes, singles tennis, those sorts of things, or really heavy labor intensive gardening, like moving boulders, building fences, that sort of thing. And we know that the physiologic benefits of exercise are numerous. They're more powerful than any single medication we have. And this picture I pulled here is from an ad campaign in the United Kingdom, and this is true. If we could put fitness in a pill, it would really, everybody would want to be on it. We know that exercise reduces triglycerides, raises HDL, the good cholesterol, it lowers blood pressure, it helps with weight loss and weight control, improves glucose metabolism to prevent diabetes, reduces the inflammatory markers we can measure in the bloodstream, and then all these more technical studies that I won't get into, but scientists have shown that vascular health is better in people who exercise. And what's great about exercise, if you look at these curves, the biggest bang for your buck is going from being sedentary to just doing something. Almost all of the risk reduction, when you look at risk versus quantity or volume of exercise, the risk falls with just a low amount of exercise. So a little bit goes a long way. So this figure on the left, this is when you quantify people's exercise volume by multiplying the number of minutes they do per session and then multiply it by the METs. That chart I showed you on the previous slide, you can assign MET values to specific exercise tasks. So here in patients who do a modest amount, their risk reduction is 40%. So their risk of cardiovascular mortality falls 40% compared to a sedentary person. And then as you do more, the risk reduction, there's really not additional. It plateaus, which is interesting. There might be other benefits to exercising more, like personal enjoyment, mental health, stress reduction, et cetera. But for cardiovascular risk reduction, you get almost all of it, or like just by doing a little. Now, this figure on the right just shows us that vigorous activity is even more efficient than moderate activity. You'll get more of a risk reduction. There's a steeper reduction in risk by engaging in vigorous activity. So if you like high intensity interval training, Orange Theory, Peloton, that stuff is great. And you only have to do 75 minutes a week. Oh, and another, sorry, I had a delay advancing the slide. There's this question about, is there a sweet spot? Sometimes people worry, can there be too much exercise? And for most people, really no. But this data shows us that no matter how you slice up, how you measure the exercise, whether you're looking at time per week, distance per week, frequency of exercise sessions per week, total amount, or the speed at which you run. This was a study in joggers. Again, all that risk reduction when you divide the people up into groups or quintiles, so 5 different groups, all of the risk reduction is in that first quintile compared to the sedentary person. Now, sometimes people have concerns. They've heard stories. A friend died suddenly while exercising at the gym, or fans of Sex and the City. We've got Mr. Big here. This just made the news last month because Peloton stock fell when this TV character died in his bathroom after using the Peloton. So people worry, what is my risk of having a cardiovascular event while I'm exercising? So the majority of sudden death during exercise in adults is due to coronary disease. And it is true that the risk of a heart attack or sudden death during exercise is higher, but that exercise over time lowers one's global risk. So some people think of this kind of like a paradox. So while you're actually exercising, your risk is a little bit higher, but the cumulative benefits of exercising frequently, that lowers your risk to a much greater degree. And that's shown in this figure here. The odds of having a cardiovascular event during exercise fall precipitously in people who exercise frequently. So this first bar are sedentary people. And if we compare people who exercise 1 or 2 times a week, 3 to 4 times a week, or greater than 5 times a week, you see their risk of an event while exercising is much lower. So if you have concerns, if you're currently sedentary and you're thinking about embarking on an exercise program, that's a great opportunity to talk about your cardiovascular risk with your doctor or your primary healthcare provider, practitioner. A stress test might be considered for people who are going from sedentary to more strenuous activity if their risk is high and people want to be sure that exercise would be safe. But I want to reassure you that all of the benefits of exercise vastly outweigh that very small risk. Now, the last few slides I have are about aspirin. This was another thing that just came up in the news recently. What about aspirin, doc? Because this was blasted all over major media outlets that most adults should no longer take a low-dose aspirin. It was popular 10, 20 years ago for really, there was a time when all men over the age of 50 or 55 were told they should be on a low-dose aspirin. That is no longer recommended for most people for prevention. And this is a screenshot from the U.S. Preventive Services Task Force, and this is the announcement that made the news. So we have a task force funded through our government that answers these types of questions. How can we prevent disease in the population? And they looked at this question of aspirin, and for adults over the age of 60, the U.S. Preventive Services Task Force said that we should not start those patients on aspirin to prevent heart disease. Now, this is only for prevention, and I want to emphasize that because some of my patients are coming to me who've already had heart attacks or heart procedures or strokes, and they should stay on their aspirin. But for prevention, for most older adults over the age of 60, we should not be starting it. And the reason is there's a risk of bleeding. And although the U.S. Preventive Services Task Force is what made the media news recently, this is really very similar to what was already recommended in the American College of Cardiology guidelines. And this is a direct quote: aspirin should be used infrequently in the routine primary prevention of vascular disease because of a lack of net benefit. And the net benefit we're talking about here is that aspirin will lower risk of heart attack or stroke, but it's offset by an increased risk of bleeding. So sometimes that's GI bleeding, or rarely and more catastrophically, that would be like bleeding, intracerebral bleeding in the brain. And these here, I've just shown 2 recently completed randomized clinical trials where patients were randomized to either an aspirin or a placebo pill. And this first trial, Ascend, did that in patients with diabetes, and then Arrive studied that in moderate risk adults. And there was numerically fewer vascular events in the aspirin-treated patients, but there was increased risk of bleeding. Now, what's my take on aspirin? My take is that a low-dose aspirin really does reduce the risk of heart attack or stroke. And for certain very high-risk older adults, I still think it's appropriate to treat them with aspirin to prevent a first event. And the reason I say that is when you look at a population level and you count up all the events in a big group, there might be a net offset where you get a certain number of heart attacks and strokes and a certain number of bleeds, but for the individual patient in front of you, they might only have one of those events. So for the patient in front of me, if I think their bleeding risk is low and their vascular disease risk is very high, I would still recommend a low-dose aspirin, but that's a small group of people, and that's after a discussion. And I would highlight that one of the criticisms of those U.S. Preventive Services Task Force guidelines I just talked about, they didn't talk about the clinical scenario of patients who've had coronary calcium scores or other types of testing who have not yet had a heart attack or stroke, but have imaging evidence that they already have atherosclerosis. And if you think back to that slide I showed you, the patients with high coronary calcium scores, they have very high event rates. And that would be a group where I would definitely prescribe aspirin, even if they were over the age of 60, because I think their risk of a heart attack or stroke is much higher than their risk of having a bleed. So the take-home messages I have for you is that all adults should periodically assess their risk of atherosclerotic vascular disease with their primary provider using a validated tool like one of those risk calculators. And then for patients who are at intermediate risk, we can use specialized testing to further refine our risk prediction and help guide decisions about therapy. For diet, the best diet for most people for risk reduction would be a Mediterranean diet, but a plant-based diet would also be great. When I talk to patients, I try and keep it simple and set achievable goals. Really strict or prescriptive diets are hard to follow. I like the Mediterranean diet because there's a lot of variety in what patients can choose from, and lots of cookbooks, online resources. I think exercise is the best medicine. I'm a big proponent of exercise, and I always emphasize to people in front of me that just a little bit goes a long way, because I don't want them to be discouraged if they can only exercise twice a week, because that might be enough. And then lastly, aspirin is not indicated for prevention purposes for most people, but I still recommend it for my highest risk patients. And I just want, before we take questions, I just want to highlight that we have a few other things planned for this month for Heart Month. We have Dr. Ruchi Kapoor talking about food and nutrition tomorrow. And then on Friday, we have Dr. Marta Ahama Balato, who will be talking about blood pressure management. And then we'll move from prevention into specific conditions next week. And Dr. Nazem Akoum will be talking about atrial fibrillation. And then John Michael has more planned later in the month for diagnostics and treatment. So be on the lookout for social media. I think a lot of you heard about this talk through platforms like Facebook, and there'll be more announced. My clinic, where I see my outpatients, is here at the Eastside Specialty Clinic in Bellevue. I also attend at the main Montlake Hospital and the critical care, the cardiology critical care unit. And then we have several other cardiology locations if you would like to be seen by a cardiologist. And this is the phone number you could call to make an appointment. And with that, I'd like to say thank you very much for having me. And we can, I think I'll take questions now. There's just a couple.
Yeah, will you run through the questions that were typed, and then if anyone else has a direct question after those are answered, if you want to raise your hand and ask a question, I can unmute you, or you can type it in right there to the Q&A section.
Okay, great. So the first question from Julie is, could an elevated CRP be indicative of something other than cardiac? And the answer is yes, definitely. So it's always important to consider what else is going on when that test is measured. Rheumatologists use CRP to monitor patients' treatment responses to certain autoimmune conditions. If you have just gotten over an illness, your CRP will be elevated. Systemic like infections can elevate the CRP. So yeah, definitely important to consider the context. And that's one of the limitations of that test for cardiovascular risk prediction is it can, if the test is elevated and people aren't aware that something else was going on, it might falsely elevate your risk assessment. So it'd be a good idea to consider repeating it. And then somebody asks, wouldn't we be better without oil? And I think it depends on the type of oil. We know that olive oil there's benefits observed in multiple types of studies. So that's the specific type of oil that I recommend for cooking or food preparation as a replacement for butter or other like higher risk vegetable oils. But if you have more questions about diet, I'd encourage you to tune in tomorrow with Dr. Kapoor.
Any other questions from the audience? If not, if you do have any other follow-up questions or would like any information, you can reach out on our Facebook page. Our email address and phone number is also available there. Oh, we did get another Q&A in. But if you do have any follow-up information you'd like or feedback for us, please let us know. And thank you so much for attending, but we'll get this last question.
Last question, would one be harming themselves if they don't use oil at all? And no, I don't think you'd be harming yourself. And I'm not enough of an expert in dietary science to say, I think typically when people look at something like olive oil, they're comparing it to another replacement nutrient or oil type of oil that would be used instead, and that seems to be the best choice. But I don't know. I would worry about, I guess, your palate if you don't want any oil at all. So I'm a big fan of olive oil in the Mediterranean diet. All right.
Great. Thank you, Nancy, and thank you everybody for attending. Thank you, Dr. Moorman, so much for the time. More on all of this and everything coming up later this week and the rest of the month. Thank you, guys.
All right. Thank you. Good night. Have a great Heart Month.